Hi everyone, it's your friend Doris Thecoder back with another video. If you are new to my channel, welcome. If you're coming back, thanks for coming back. This video is going to be for anesthesia reimbursement professionals. Today we're going to talk about some of the changes you can expect in the ASA with regard to anesthesia reporting. Now, first things first, we do not have any new ASA codes for the calendar year 2023. So if you wondered that, you just want to know that, you got that video and you're done. However, it is important to note that we do have some changes in our crosswalks this year, so as well as new CPT codes. I think when the codes come out every year, it's really important to look at new CPT codes, because where I see, outside of IR altogether, where I see probably the most, I guess, disagreement on my part when it comes to some of the ASA choices is in IR, but also with some of the newer codes. You've got to remember, when you think about the ASA's job and the AMA's job, they have to go through what is equivalent, I think, close to 11,000 codes we are at this year, CPT codes. I have not totaled that to see how many surgery codes there are, but they've got to go through all of those codes and then try to compress them into the nearly 300 ASA codes that we have. So that's a hard job. This is why we advocate for everyone to kind of take part in the process. If you think a code isn't properly crosswalked or valued, follow the guidance in front of your ASA book and write the ASA, give the rationale, so we can work together as a specialty to get it aligned. So first, we've got a few revisions in our ASA crosswalks. A couple of the codes, our codes for the infusion of an injection or infusion of a neurolytic agent in the spinal areas, whether it's subarachnoids or epidural. This is the code range you would deal with. If you look in your ASA today, you'll notice they route you to 01941 and 01942. The challenge with that code, so this is the code range, the challenge with 01941 and 01942 is these codes are for neuromodulation or intravertebral procedures. By structure alone, those codes don't fit even today, in my opinion, because the subarachnoid space is not within the vertebral body, nor is it a neuromodulation or spinal cord kind of stimulator procedure. So you could technically look in front of the ASA book and follow the guidance and deviate today, because it's just never been a proper code. If you attended the Advanced Specialty Conference that was just in Dallas, or you attended the conference in Vegas this year, I talked about what happens when you don't maybe agree with the crosswalk and some options where I did not. This was one of the codes I did not agree with, because I said I don't think that's not the right structure, and now we have them aligning and correcting it. So maybe someone did the work I was not able to do this year, because I actually did not get to write this one into the ASA to get that changed. Maybe someone else did, and if you did, I'm grateful for you. Thank you very much for doing that. But effective 2023, you'll actually see the new crosswalk in the ASA book, or electronic crosswalk if that's what you use. Another code they made changes to was this, and you know, this is a little weird, because if you look just kind of at the level 92502, they are actually, it showed up as a change, but they changed the order. So the CPT code still has the same ASA options in a different order. And I guess otolaryngologic examinations, because they cover multiple structures, this is probably where your ASA is coming from. So if you get an incomplete examination, maybe that doesn't include the nose, or doesn't include all the structures as evidenced by that code, then you would possibly be able to use one of the alternates. But it covers both the ears and the throat, and I guess everything in between. So this is why you have the same options, 00170 as opposed to 00120 and 124, just based on all the areas in between that are being checked. They're putting the primary one as 00120, where the primary one was 00170, and I guess I should correct my verbiage there. Primary, it's just the first option. That doesn't kind of mean anything if it's not your structure, but I found that one to be a little bit strange that they actually put multiple ones there. Another one, and this is one that I think I'm going to write into the AMA on, they've included the 33536, and they've just given you some instructions under that code to say, remember, they removed the instruction for 33530, but surgically it's not removed. Like if you're still doing 33530, and for surgeons, that's when your surgeon does a reoperation more than a month after the operation, because scar tissue can grow and it's a little more complicated technically and clinically for the providers in the management state. They removed the instruction. I'm not sure why they removed the instruction, because I think it would still be valid as far as the utility for that code, but that is what we saw in the crosswalk for this year. Another one, and this is another one where I say, even though the effective date of this is going to be 2023, in your crosswalk, thrombolysis today is routing to 01920 in your crosswalk manuals. However, thrombolysis, just in the CPT description itself, that thrombolysis is when they actually break down a clot. Thrombo is the medical word part for clot. So they actually are infusing a thrombolytic into the coronary arteries to eat up or dissolve or break down a clot that's in the coronary arteries. That is a therapeutic procedure. One, you have the problem of a thrombus. Secondly, we're actually going in to do something with it. That's what lysis means. We're going to treat it. We're going to destroy it. We're going to break it down. So I am not sure why they routed this to cardiac catheterization. Yes, they do have to do a coronary catheterization to infuse a thrombolytic, but it is still a therapeutic procedure specifically on the coronary artery. So we did see this one aligned. So if you're working in the adult space, therapeutic interventional radiological procedures involving the arterial system. Again, if you attended the Advanced Specialty Conference, I talked about interventional procedures, diagnostic versus and looking at the structure. So we get a better crosswalk. I think the more appropriate crosswalk written in the ASA manual as of 2023, but that's one where you might say, well, hold on a second. It's still a therapeutic interventional procedure. In most of the image-guided going through the arteries or going through the vessel procedures are interventional procedures. All interventional procedures are minimally invasive procedures that use some kind of imaging modality to accomplish them. So instead of cutting this patient's chest open and cutting into the coronary arteries, they actually just went through the arterial system, made their way into the coronary artery via cannulation, and infused a thrombolytic inside of that. So that's another one that we're going to see in 2023. They've actually, for completion, added the proper crosswalk for site for 20240. 20240 just covers a lot of different sites. And again, this is where you're in the general part of your CPT, where they talk about bone biopsy, musculoskeletal part of CPT, where they talk about biopsy of the bone. They don't kind of group bone biopsies, open or percutaneous, under the anatomic site. So if you look in your surgical CPT book, the surgical section of your CPT, you'll see they'll put, shoulder and elbow and, wrist. They have the different anatomic sites, but this is in the general section of musculoskeletal, so it doesn't have the specificity of the location included there. That means from an anesthesia perspective, we have to be really mindful of that specification when we code. And remember what you were told at that conference, be careful when you're doing bone biopsies, especially those that are percutaneous, because you might have a better option in the code that we discussed there. So they did add 00190 there. It was not included previously, but when we look at 00190, that's facial bones of the skull. So that's any facial bones or the skull. So that could be at the head, that could be the jaw, that could be the sinus, that could be anything on the face, anything that you're looking at kind of right now. And then they actually added an update crosswalk for a cranial fossa procedure. So with intracranial procedures, they can actually approach them many different ways, right? So they can go transorally, they can go through the ear, they can go through, in this case, transcondylar. So different approaches. 615, 97, and 98, they actually added an inclusion text or an instructional text, and this is why I think it's really important that you buy the relative value guide in addition to the Crosswalk, either paper or electronic, whatever kind of works best for you. I buy both because I prefer paper. I kind of am used to that because that's what I started with. But when I travel, I've learned that our coded manuals are very heavy, so I don't like to really take those because I don't want to pay an extra $100 bag fee for a book just so I can work. So for these codes, 65798, 7 and 9A, for those transcondylar or transpetrosal approaches, for those cranial procedures or intracranial procedures, they actually added text that routes you to 00216. 00216 is the code, the ASA code that we use for intravascular procedures. So you have to watch my screen there. Intravascular cranial procedures. So your structure, your target, you need to do something on a blood vessel. Now you do want to know anytime they incise and they do incisions, there's going to be some blood vessel protection. But you might be looking at something like moya or a tumor that's got a lot of vascular compromise or something like that, not simply because you see a blood vessel in the report. That's largely going to be your structure there. So those are the only changes that we see with regard to ASA crosswalk revision. So we've got no new ASA codes, and these are the crosswalks that are revised for 2023. So again, be careful if you're coding by memory and you're used to seeing some of those procedures so often. I think some of the mistakes we make as coders, we know these codes, like we know them very well. So we don't have to look them up every time they come across our desk or report. By the time we get to the middle of that report, we know exactly what the ASA is. So be careful, because in this regard, your memory can be really work against you in this regard. Now we'll look at some of the new codes, and I won't go through all of them, but I do want to give you an idea of some of the big one. And I did promise for those of you who attended the advanced specialty conference that I made a prediction on how the code should be crosswalked if they didn't come out this way. And I'll start with this code set. So 33900, we have finally, if you're working in the cardiac space, I'm going to do another video on cardiology for the changes we can expect there and some of the guidance. But if you're working in cardiology, we finally have, after God only knows so long, thank you so much, SCI, the Society for Coronary Angiography and Interventions, because I know them, coupled with ACC, were very, very integral in getting these codes in the book and getting them valued properly. So we now have codes in the cardiac space for pulmonary artery stent placement that's unique to pulmonary artery stent placement. And this is one that I was most concerned about because we have a pulmonary angioplasty code 92997 that's appropriately walked, but the only code we had was 37236 when we were doing pulmonary artery. Pulmonary artery stenting, and it value for what's there, I don't think it was properly valued for it. So now we've got a unique code, and I actually predicted it right. So it is crossing to 01926. I recommended that whether it crossed to 01926 or not, that you should report that, because that's the best code for it. And when we looked at all the different options, it routes there. So we've got different ones consistent with the nomenclature that we see within CPT and the instructions on normal native connections or abnormal native connections. Those codes still exist. So if you had a Fontan, for example, that was stented, that'd be an abnormal connection. So that's really important. That's important to know. And this again is routing to 01926. We've got a great number of codes they created. Also vascularly, we have a code if you're working in the vascular IR space. We have a new code for percutaneous arteriovenous fistula creation. We actually got kind of a couple codes there. So really, really great. That too, it's not crossing to 019, but it's crossing to just the AVF code. So that 01844 is how you're going to end up reporting those services if your providers are doing these. Just for clarity, in AVF, you might see it as an AVG documented. So arteriovenous graft, arteriovenous fistula. All that really is connecting to things that normally don't connect. So whether they do that by anastomosis, that is making them kiss directly, or they do something like putting a tube between them to make them connect, right? Both of those would reflect our AVF or AVG. And when done percutaneously, which is an option now, you're going to cross that still to 01844. You've got a lot of new codes as well that pertain to hernia. We've got a huge range. And where we'll have to pay attention in anesthesia is we'll need to look out, as we always have, for incarceration or herniation. What did I do? I didn't do the right number. For that code range. So we have a great deal of codes. Now there's greater specificity in size. So if you're working surgically, you're going to have to pay a little more attention and detail than we are. It's not going to change our ASA based on the size of these, but you will need to pay attention to approach, of course, always, as you did before. But notice they said open, laparoscopic, etc. And you'll need to pay attention to the terminology of incarceration or strangulation, because if you see incarceration and strangulation, typically that requires a level of exploration that the reducible or non-incarcerated or non-strangulated hernias require. So you are going to have a higher value procedure, but you'll need to look for that terminology in your pre-op evaluation, in your operative report, in your anesthesia record, whatever data you have that you're using to code. Be aware of incarceration and strangulation, right? Because we're now squeezing on organs and there's compromise to those organs. That's sometimes what's the difference between a medically necessary hernia repair and a non-medically necessary hernia repair. They may not be attractive, but unless there's incarceration or strangulation, depending on the size, a payer may say it's not necessary for you to repair it. We've also got a new code for laparoscopic prostatectomy, so I think that's crossing the way we normally would expect it to. We've got a code for transperineal BPH ablation. That's also crossing actually very low, 00920 to just genital procedure. We've got codes for nasal valve collapse repair. That's a new code as well. That's also crossing to the general nose code 00160. So nothing new there to think about. And I'll leave you with the spinal one that we have. I think it's a really awesome code, but it speaks to what we have to be aware of as an anesthesiologist, and this may not be a coding things for those business managers and executives in anesthesia or things like that. It's important for you to be aware of this. There's now CPT unique enumeration for the intragastric balloons. So there's this procedure now, they've been doing it for years, endoscopically. They can actually go in and put a deflated balloon into your stomach, blow up that balloon, fill it with like saline so you feel full longer, and it's a weight loss, like bariatric type procedure. The challenge with it, and I did a little research, I'm not finding payment with any payer for this procedure. So don't think just because we have a CPT code for something that we have coverage for that same procedure, because case in point, we have CPT codes for breast augmentation. Doesn't mean your insurance company is going to pay for breast augmentation unless you're after you've had a mastectomy or something. Generally, it's an elective procedure. It's cosmetic. It's not medically necessary. So is it a CPT code for it? Yes. Do you have an anesthesia code that goes with it? Also, yes. You're going to use probably 00731. I don't know them to do that procedure with lower endoscopic procedures, but you're going to see in your ASA book that they have 731 and 813 as an option for you. I think you're just going to end up with 731, but it's important for you to note just because you have coverage or CPT for it doesn't mean you have coverage. And if the service that anesthesia is being requested for is not medically necessary, then the anesthesia for that service is also not medically necessary, as well as any services associated with it, facility fee, whatever, right? So be mindful of that if you're on the business side of anesthesia outside of coding, because I can code it the way I code it, and it's still going to crosswalk the same way. That does not equate to payment. So there really has to be someone on the AR or practice management side that's ensuring that you're doing that kind of diligence when those procedures are scheduled, because you better believe the surgeon knows whether it's covered or not, and they've probably done some kind of self-pay arrangement with the patient, because again, I can't speak for all across the states. I did a bit of research on these procedures, and I have not found a single payer policy that covers them. In fact, United and Medicare does not. It's actually published in their policy. So looking at a few of those, just bearing that in mind, if you do see that bariatric procedure in your notes documented, you may want to make sure you've thought about your anesthesia provider and reimbursement. So just wanted to give you a general kind of overall what's going on. We do have another code for abdominal wall mesh implantation. We're seeing that 15778. That's crossing as usual. It's not a deep procedure. This is going to end up with your subcutaneous procedures. This code right here. So when they've got to close a defect or soft tissue or trauma, we've got a new code that's allowing you to crosswalk. You can see your ASA for that. And on that intragastric balloon, there's actually an NCD on that. So that may help you make a decision when you're thinking about Medicare Advantage plans versus Medicare. If there is a national coverage determination on a service, the Medicare Advantage plans have to follow national coverage determinations. They don't have to follow local coverage determinations necessarily, but they do have to follow NCDs. And it is an NCD for intragastric balloon, bariatric balloons that indicates non-coverage. So I'm going to stop the video with that. Hopefully that's thorough enough for you. Pain, it's a whole different side. I want to split those because I understand there are some coders that just do anesthesia and don't do pain, but we do have some changes there as well. I would say follow the page, and I'll put the link in the video to the FAA, the FAAA, if you are in Florida. That's the Florida Anesthesia Administrators Association. We are planning to actually do a conference on the blocks, the update with regard to chronic pain, so stay tuned for that. Subscribe to my channel. I'll put the information there. You can also check out my friend Kelly Dennis's channel. It's Kelly's Anesthesia Tips, also on YouTube. We'll keep you apprised of what's going on. So until the next video, thank you for stopping by. I'm your friend Doris, Thecoder. You know what I say, like it if you do. If you find the information helpful, don't keep it to yourself. Share it with a friend. And always you want to subscribe and sign up for notifications so you know when I post, which is as often as my schedule allows. And until the next video, I'll see you then.